So, danke, Franz, Hans. Ja. Für die jüngeren Kollegen mag nicht so geläufig sein, dass Hans Chiari den Zusammenhang zwischen Karotis Thrombose und Hirnembolie erstmals beschrieben hat, 1905, in seiner Publikation über den Teilungswinkel der Arteria carotis und seine Relation zur Hirndurchblutung. Das ist auf unserer Homepage und ich ersuche Sie, das nachzulesen. Der Hans Chiari gewürdigt hat, war niemand geringer als Miller Fischer, der ihm, Hans Chiari, zugesprochen hat, dass er das war, der Erste war. Und damit ist es sozusagen vom Begründer der weltweiten Schlaganfallmedizin, Miller Fischer, sozusagen amtlich, und dieses Erbe sollten wir stolz für uns hertragen. Was Professor Fazekas angedeutet hat, war, dass Hans Chiari auch tatsächlich in den USA war und Vorlesungen gehalten hat, unter anderem 1910 in Johns Hopkins University, und das ist heute der Gegenbesuch nach 100 Jahren. Ja. Professor Daniel F. Hanley Jr. Ist Jeffrey Harriet Legum Professor of Acute Care Neurology in Johns Hopkins Medical Institutions in Baltimore, USA. Seine Expertise reicht in die Grundlagen Medizin, Grundlagen Neurologie, Basic Physiology der zerebralen Regulation. Er hat erforscht Mechanismen der hypothalamischen Regulation und die abnormen Verhaltensmuster des Gehirns in Beantwortung, in Reaktion auf Verletzungen. Er hat diese Erfahrungen direkt angewendet auf klinisch-pharmakologische Studien und klinische Physiologie sowie klinische Trials, die traumatische, ischämische, hämorrhagische und Infektionsstörungen des Gehirns betreffen. Er ist ein Graduate von Williams College und Cornell University Medical College. Er hat eine Board Certification, wie wir schon gehört haben, in Innere Medizin, in Neurologie, in Psychiatrie. Er ist der Gründungsdirektor und leitete über 17 Jahre eine kombinierte Einrichtung Neurochirurgie und Neurologie und Critical Care Unit at Johns Hopkins Medical Institute. Diese Einrichtung wurde das regionale Zentrum der Exzellenz und ein international anerkanntes akademisches Forschungsmodell. Er ist auch Professor für Neurologie, Neurochirurgie, Anästhesiologie und Critical Care Medicine an seiner Einrichtung. Er ist zusätzlich auch Professor of Nursing an der Johns Hopkins School of Nursing. Gegenwärtig ist er Direktor des Brain Injury Outcomes Programs at Johns Hopkins Medical Institutions. Er ist natürlich ein Mitglied zahlreicher Fachgesellschaften und hat viele Preise gewonnen, unter anderem den Alexander Humboldt Research Prize for Accomplishments in Brain Injury Research. Er gründete die Critical Care Neurology Section des Journals Critical Care Medicine und ist Associate Editor für diese Section. Er hat mehr als 20 Basic Research Grants bekommen, hauptsächlich von den National Institutes of Health. Er hat weit über 100 Publikationen in absoluten Top-Journalen unseres Faches geschrieben und ist weltweit anerkannt in seinen Spezialisierungen. Then you have come from China now and Abu Dhabi, looking for sites to enhance your clinical trials. Hopefully you find one or two here also in Austria. that makes your stay worthwhile, but being worthwhile it is to us to have you here again in Krems. It's indeed an honor. We will help you to dodge the blizzard at home right now and might keep you for another day, which you would thoroughly enjoy. Eine Sache, die Professor Hanley auch auszeichnet, ist, dass er sich ganz intensiv bemüht um seine Residents und Fellows und ein großer Freund auch von Europa ist. Seine Kontakte sind wirklich großartig und we are very proud to have you here today, Dan, and ask you to accept the honorary membership of our society. Could you please come up?
I have, this is a wonderful honor, and I want to thank all of you. It's very nice to be here in Krems again. I have a small return gift, a USB. I hope I can stay within my half hour, but the story of Hans Chiari coming to Johns Hopkins, my staff went to the archives, and all of the material for his visit is here, so that Michael can put it on the website. And I have some pictures to show you. I enjoy being here very much because I always learn a lot from the exchange of information about how people are doing good care for neurology patients in Europe. And that's really the story of Hans Chiari. This is his Wikipedia webpage. And he has a lot of anatomic contributions as well as the first description of TIA. This is the publication of his lecture. On the left is the original hospital of Johns Hopkins with the dome, which is now the insignia of the medical institution. And they had this is in a time prior to journals, so the hospital bulletin was, in effect, a journal publication. He was the Christian Hertler lecturer. I don't know about Christian Hertler's parents, but he has to have German parents. It's a German name. His father was a tailor, and was a very rich and successful tailor, and Christian Hertler became a biologist and was trained by William Welch, the first pathologist at Johns Hopkins. Hertler went on to a very important career studying the microbiome in the intestine in 1900 and linking biochemistry to medicine. He was a professor of neurology and of experimental neurology at King's College, which is Columbia College of Physicians and Surgeons, and he died at a very young age. But because of his family wealth, he was a wealthy man, he and his wife left $25,000 to Johns Hopkins, where William Welch was. And even though he wasn't trained at Johns Hopkins, he was dedicated to his mentor, William Welch. And the gift was to promote a more intimate knowledge of researchers of foreign investigation in the realm of medical science. At that time, Johns Hopkins was a very young university. It was, the medical school was 5 or 10 years old. It was modeled on Charité University in Berlin, and there was great respect for international science. And arguably the best medicine in the world was being done here in German-speaking countries at that time. So it's not surprising that Hans Chiari would end up giving a lecture at Johns Hopkins. This is Christian Hertler. His biggest legacy may not be the Hertler lecture, but he started, edited, and funded himself the Journal of Biochemistry. He endowed the journal so that after its death it continued. This is Paul Ehrlich was the first Hertler lecturer, and you can see that Hans Chiari was in very rarefied atmosphere. This is the actual official invitation to his lecture, and it wasn't one lecture, it was 3, over 3 different days. Each one is about 4 pages of academic discussion in that Johns Hopkins bulletin I showed you. Some of it was illustrated. This comes from his observations on spondylolisthesis and is an actual anatomic pathologic specimen, nicely showing spondylolisthesis. Again, the bulletin, and this is the kind of detailed description that he gave. It's a high quality, would be published today as an important overview. It's with a lot of pleasure that I come back, and it's a true honor to be here and to show you a little bit. I apologize, I can't show you everything about my most recent work because it's embargoed until February 18th. But I'm going to give you a quick overview, as much as I can in a half an hour, of hemorrhagic stroke and trying to reverse hemorrhagic stroke. Werner, yesterday, I think made a lot of very nice comments about how rapidly things have changed in the last 2 years in interventional ischemic stroke. It's built on a foundation of 20 years of the idea of emergent revascularization. We're following in that trail, and we're not as far behind as people might think. The key concept, though, for treating hemorrhagic stroke, I believe, is clot reduction spares tissue. We have significant high-quality Class 1 evidence about blood pressure reduction and stabilizing the clot, and about tissue at risk and the use of vascular imaging, and lots of good data in parallel to the ischemic stroke story about how to do secondary prevention and how to start it, secondary prevention in the hospital. Where I've been working now is in image-guided removal. We're not in the same place as we are for interventional radiologic approaches to ischemic stroke, but we're setting a good ground, and I think we are getting there. And if I were to summarize what I'm going to try to communicate to you, we need to understand the patient selection factors, and we need to persist in producing a high-quality removal of clot from brain tissues. This is, in a single slide, the lessons from MISTI 2 for high-quality removal. On the left-hand side, you see modified Rankin bars with good at the top and death red at the bottom. And they're separated into 4 quartiles, from good removal on the left to poor removal on the right. And you can see that functional change in Rankin has a relationship to removal. On the right is a relationship that relates to how close to the clot you get the catheter that's used to remove blood in this program, and how well or how poorly you remove the clot. So there are technical aspects in what we do that are exceedingly similar to the evolution that has led to the stent retriever and to a high frequency of fully opening intracranial vessels. The thoughts that we've been pursuing, and now I think others are starting to follow them, is the main thought that's helped us with interventional ischemic stroke. And that is, you have to break the disease down into subtypes. Time is so important in ischemic stroke, but location is maybe the most important part of hemorrhagic stroke. So this is a Venn diagram of the overlap between intercerebral hemorrhage and interventricular hemorrhage. And about 40 to 50% of all hemorrhages have both. About 30% are just within the cerebral tissues, and somewhere around 5 to 10% have a very large component of interventricular hemorrhage and a small component or no observable ICH. And that's the subpopulation that we chose to look at in CLEAR. These are my last 3 trials, and the recruitment of the STITCH trial put on a neutral time axis. The MISTI 2 data, which is only 110 patients, took us a long time, but we went after this issue, as you can see, of how to get more and more clot out of the brain tissue location. We had done that in a phase 2 trial with CLEAR, which I'm not showing here. The CLEAR trial is the green line, and recruitment was at about the same rate as occurred in STITCH 2, David Mendelow's trial. The black line and the dotted part are the year 1 and year 2 of MISTI 3, and the big arrow is now. It's actually January 1st, where we're at about 255 patients in a 500-patient study. What I want to show you today is where we stand with the green line, and I can't show you the active treatment and control data, but I can show you all the data and the safety data. The MISTI program, just to give you one picture of it, is best summarized in this single picture. A image-guided, minimally invasive burr hole or twist drill, and there are a lot of technical reasons for which one you want to choose, image-guided into the long axis of the middle of the clot, can, over 48 hours, produce dramatic clot reduction, which you see in the sequence in the top panels. And the bottom panel is a 3D reconstruction of clot shrinkage. But I want to talk today a little bit about the CLEAR program. Hopefully you'll get to read about it in a publication soon. We submitted the paper 2 days ago. and we hope it gets a favorable review. In clear, you have to put the catheters into the ventricle, and the fundamental problem that we had to deal with in ethical and clinical trials situation was that the catheters were being put in for the indication of possible treatment of ICP. And although there was not randomized clinical trial data, there was practice data. So we had to accept variation in practice at the start point of the trial. We tried through several sets of meetings to come to a consensus over what might be anatomically or physiologically correct, and we couldn't. And interestingly enough, it was a European partner in Cologne a decade ago, before the phase 2 trials, Andreas Unterberg, who said, so what we have to do is accept that practice is what it is, and the clear patient, the patient with the small ICH and the large IVH, is the patient who the physician chooses to put the catheter in. And that's the starting point of both the CLEAR 2 trials and the CLEAR 3 trials. And as you can see, the catheter most often, about 75% of the time, gets put contralesionally. Contralesional is a complicated idea. There's both the interventricular lesion and the intracerebral lesion. But some catheters get put in ipsilesional. There are advantages to both. The contralesional catheter is in a CSF pool, can drain CSF, more easily and more immediately control ICP. It may not control it perfectly. In fact, our data shows that, the data that we'll get to see in February. The ipsilesional catheter has the advantage of the what I showed you in the MISTY program, that it's very close to the clot. You're delivering an active drug to a safe place into the clot, and it has higher and more rapid activity in that location. And here's an example of that. After only a single dose, you see the ipsilesional catheter in the top panel, and after only a single dose, you see that most of the ventricle is clear. And this is the example of the opposite. A ventricle laden with blood, the catheter is contralesional, and in many ways that's good for draining CSF, and this has a mass effect, so ICP more likely than not was high in this patient. But there was no removal in the upper two panels when TPA was administered into that trapped ventricle. The TPA couldn't get through the foramen of Monroe and back up the other side. Bottom panel, lysis occurred within 3 doses, and it was nearly complete, as you can see. Once an occipital pole, and it's a little hard to see, but here it is, catheter was placed closer to the clot. If you look at an overview of meta-analysis of single-site trials, case series, there are 3 that stand out and are comprehensive for all of the experience in case-controlled and non-case controlled series. The Dutch one from 2000, the Austrian one now from Eisenstadt, although Dmitri Stakov did this while he was in Erlangen, and I think it's Thomas Gabrel from the French city of Caen. What they show, if you just use an EVD, and these have all the problems of selection bias that case series and small trials have, and publication bias, where they may overestimate things. They show that mortality is around 50% if you just used an EVD, and that good outcomes are not in a great proportion, from 15% up to 35%. I'd like to show you two even more recent studies that give us a benchmark for what happens with the small ICH and the large IVH. There are two that I worked on. The first one I worked on with my collaborator Bo Norving, Arne Lindgren, and their student Bjorn Hansen, and it's part of his thesis. It's just published. You can find it electronically now. It's in neuroepidemiology. And almost a year ago, we published another epidemiologic study, a healthcare delivery study from the United States. And I want to briefly walk you through both of those. This is Bjorn Hansen's study using the well-established Lund stroke registry, which is established that it doesn't miss any patients, so it's a true epidemiologic picture of a region. We undertook this because Bo Norving said we should be careful not to just have randomized clinical trial and case series data, like I summarized from the meta-analyses, but we should have epidemiologic data where we looked at the disease in a geographic region and be able to compare that and say whether the general population was the trial population or not. We were able to utilize the fact that functional outcomes determined by telephone is acceptable for all patients in Sweden, and we used their 90-day outcomes. And we were able to access the images, which is a flaw in almost all the epidemiologic data, because as I suggested in the Venn diagram, the real severity knowledge comes from understanding where the blood is and how much is there. Bo Norving agreed to help us provide an epidemiologic benchmark. This is it. On the top plot is a survival Kaplan-Meier curve for different grades of IVH. So focus on the bottom plot first. The top line, the line that survives, and this is all the hemorrhages in Lund over about a 6-year period of time. Survival's high if the hemorrhage is just in the brain tissue, and that's because the majority of these are small hemorrhages. But once the blood spreads into the ventricle, the overall, independent of size, the overall mortality is about 50%. The red circle are the high Greb scores. The Greb is semi-quantitative but relates directly to volume, and we've shown that in other publications. The high Greb scores have mortality that looks like the mortality in Dmitry Stakov's meta-analysis. It's 80%. Good outcomes in that group of 250 patients. Once you have an IVH, good outcomes are 15% if you use the Rankin 3 cut point, which is the one that we were able to convince our colleagues at NIH was the important one to start with in looking for effective treatments for ICH. The second benchmark is this paper from Stroke in 2014 that two neurocritical care fellows, Yogesh Moriata and Santosh Murthy, did with Wendy Ziai and I. It's an unbiased random sample of all of the ICH hospitalizations in North America for 9 years. It's a 20% sample, so 1 out of 5 patients is in this series, and it's 600,000 patients taken from almost a decade of ICH experience. Random sample, we did it to define the current level of intervention for IVH and to test for possible benefits where TPA was used. TPA was not used in an organized protocol, We just have the coding that it was used simultaneously with an extraventricular drain. These are the trend lines. Of the 650,000 patients, which represents 20% of all ICHs in North America for the decade from 2002 to 2011, about 6% to 7% were treated with an extraventricular drain. The CLEAR Phase 2 trial was done where the first blue arrows are, and CLEAR Phase 3 started in December 2009, so it essentially ran from 2010 to 2015 with another year up till 2016 to collect one-year follow-up data. When you look at those patients, the 30,000 with EVDs, 1,000 of those were given some dose, we don't know what, of TPA, most likely into the extraventricular drain. When you look at those with interventricular fibrinolysis, IVF, which is this column here, what you see is 7.5 to 10% drop in mortality. If you take out those subjects who had early withdrawal of care, the drop in mortality is from 38 to 26%, about an 11% drop, and a 6 to 7% shift in early favorable discharge. That would be discharge to home or to a rehab center. So whether you take all patients or you eliminate those who, for whatever reason, futility was decided, you see the indication of a possible treatment benefit that could be important. So I think we have to understand the CLEAR trial with the benchmarks of the meta-analyses I showed you, and these two benchmarks from epidemiology. And they suggest that the IVH frequency approaches 50% of all ICHs. The mortality in IVH with a large IVH is 70 to 80% if it's managed by current best practices. The Sweden group had about a 5% use of EVDs and about a 5% use of surgery. And good outcomes at 90 days look like they're around 15%. In the US, there's a suggestion that there could be a mortality shift with treatment, but we don't know what, it's a healthcare delivery study, so we don't know what each individual patient got, and that there's a shift in discharge status. So now let's move to where we can gather more information and begin to assess what the severity factors are, which is the important lesson we learned in the interventional studies. You have to understand the severity factors and you have to understand how to select patients. CLEAR 3, starting 6 years ago, was a 500 patient study, 100 sites. The sites had to have neurosurgical and stroke expertise. It's a placebo-controlled, double-blinded randomized trial. So patients either got into their EVD, either got saline or TPA. Our power assumption was based on the phase 2 data and was a 13% shift in the Rankin, an upward shift to the 0 to 3 levels. We thought, based on 30-day data, that shift was observable. We assumed that the baseline or control level would be 23% good MRS in that 0 to 3 group. We used adaptive randomization to make sure that in sequence over the 6 years there was a balance in recruitment to the two groups, active treatment and control, for two critical severity variables: ICH location, what part of the brain was the ICH in, and the IVH size. And that allowed us to use this design where we look at the three major severity factors on the left-hand side, and we mitigated the role of ICH by having only ICHs less than 30. We randomized and then balanced IVH size between groups. And because we only took stabilized ICHs, those who we'd followed for up to 2 days to make sure that the hematoma wasn't expanding, that severity factor was taken out of the equation for influencing outcome. The patients had to have obstruction of the third and fourth ventricle. The EVD was placed, as I told you, via the Unterberg Agreement as part of routine care without specific knowledge that dictated location, number of EVDs, or timing of when it was placed. All of these probably are important factors. The rest of this we've discussed. The study endpoints, very important. We didn't know. We suggested that the animal data would show that the more clot you got out, the better you would do. But many people felt it was adequate to just give TPA because of the possible risks until the third and fourth ventricle were open. So we proposed to all sites and trained them that they had the possibility to choose from one of three sequential endpoints: opening of the third and fourth ventricle, treatment of the IVH mass, as I showed you in the IPSI catheter placement, or continuing out until they got 80% clot removal, which was a number that comes from the animal models. We tapped the toxicity exposure, the potential toxicity exposure at 12 doses, and that was in an agreement with the FDA. Oh, and this is on the right is the usual extraventricular drain apparatus. The statistical plan, primary outcome, modified Rankin 0 to 3 at 180 days, in order to be certain that the improvements had stabilized. And the secondary outcomes were all-cause mortality, the relationship between the amount of residual blood and the primary biologic hoped-for endpoint of Rankin, and the intensity of critical care management, and then safety, which was all at 30 days. We hope to see this shift in Rankin. We hoped that there was less mortality, but we thought that the mortality analysis was important in case bleeding risks from giving the TPA put the active arm at more risk. And because of animal models and all of our human data in MISTI and phase 2, where we found relationships between IVH removal and Rankin, we thought that exploring that was the best defense against the variable starting point in this first ever trial, the variable starting point being that the catheter wasn't always in a good location to remove clot. Safety was 30-day mortality, symptomatic bleeding, a bleeding that was identified and had a concurrent neurologic deterioration, and of course ventricular infection. And we hope that none of these were greater in the two groups. We were very happy with the controlled elements on the left side, and I think I've emphasized that the two areas where we didn't have enough practice knowledge were the initial use of the EVD, when to put it in, where to put it, and how many to use. I can't show you the data today, but it will be a subject of one of the two late-breaking news presentations that we'll give in Los Angeles. The second half Where we're a little bit uneasy is in green on the right-hand side. And that's what do you do to control ICP when the EVD catheter doesn't work? And that'll be the subject of a presentation in Los Angeles. And the relationship between early ICU outcomes and the amount of removal of blood. So this is, again, our data vacuum at the beginning. What's severe and what's small? We had arbitrary definitions. Severe, you had to at least have the third ventricle obstructed. And a small concurrent ICH is 30 cc's. Now, we're going to hear a little later on today that 30 cc's may be big, too, and I think that that's possible. I'll show you that our population, the average and the median were much smaller than 30 cc's. And we've already talked about the EVD placement, and it's hoped that we'll generate some information about it. The protocol, the first two steps are in red. To place the EVD, which is prior to enrollment, and a minimum of 6 hours to stabilize and be certain the clot wasn't increasing in size. To check, in order to do that, number 2 in red, you check and quantitatively measure the ICH volume, qualitatively the IVH, and you look carefully at the catheter tract and make sure there's no added bleeding there, and assess the need for a second catheter. So these are all things that, that our sites were trained on. And then the stopping points come somewhere around the white brackets down here in the protocol. The average dose in the treatment group, I can tell you that, was 4 to 5 doses, so they didn't need all 12. And you reassess based on the images whether you should stop and which stopping endpoint you were going to go after. This is the timing of the 500 patients and their enrollment into the study. You can see they were all treated as emergencies, enrolling in the ED within 1 to 3 hours of their ictus, and they immediately had a CT. A couple things to point out in terms of practice that might change. The EVD went in around 10 hours, but a huge number of them were substantially delayed. The second thing to notice is that because this was a first ever randomized controlled trial, that red bracket shows you that it took a day and a half to go through with the family the rationale for enrolling in the trial. If there's a time signal that earlier treatment is better, we have the opportunity to see it, and we also have the opportunity to change that practice if the trial shows us some benefit. These are the types of patients that were enrolled. Men and women get this disease with almost equal frequency, perhaps higher frequency if you have dark skin, so Black, African American, Asian, all have high levels of enrollment in proportion to their part of the North American and European populations that participated in the trial. There were 25% of the patients came from Europe, about 1% came from South America. Almost everybody was hypertensive. Those that were not had either cocaine use or were under treatment for atrial fibrillation with an anticoagulant. This is what the baseline labs showed. You can see about 1,000 white cells in the initial CSF. The protein is elevated and the glucose is normal. Initial blood pressure, 190 over 108 is the mean. It was rapidly controlled. At randomization, 145 over 70. High severity, GCS 9, NIH stroke scale 21. The IVH volumes, I'm giving you the mean and the median. The mean is 29 and the median is 24. And the ICH volumes, the median is 8, and the mean a little bit larger of 9. We employed this adaptive randomization. This is how the play of chance works. If you look at this, this would be one of 2 treatments, and this is the other treatment. And the first section of about 150 patients are just a regular randomized trial with a central registry. But from this point on, the green dots, after each site enrolled 4 patients, they went into a pool for adaptive randomization. And if there were a greater number of patients receiving treatment A in their IVH size group, then the subsequent randomization had a biased coin toss, an 80-20 coin toss, not a 50-50 one. And you can see that that drove the balance between each of the IVH size groups down to about 1%. And I'll show you this in another figure in a second. Here's a different version of that balance. Europe had 117 patients, and this is the balance between less than 20 cc's of IVH, 20 to 50, and greater than 50. The other thing I'd like you to see is, unlike our phase 2 data, where 35% had these greater than 50, in CLEAR 3, that's only 10% of the samples from each of these geographic regions. There's the stability volume, which I showed you a different way. It's in the mid-20s. Here's how the adaptive randomization worked. This is Group A and Group B, and you can see at the 20 cc cut point, so from 44% are less than 20 cc, another 46% are up to 60, and the last 10% here. And in each cohort, on a patient-by-patient basis, there's a full balance of sizes in each group. So it worked very nicely. This is clot location. You see that the majority of these are thalamic. 58 to 60% had the primary thalamic location. 10%, the dark blue, were so-called primary IVHs where we couldn't find an ICH. This is a bit of a shift from the phase 2 data too. In phase 2, 50% were thalamic and 50% were other. This is treatment fidelity. We removed clot down to about 10 cc's. Said the other way, we left 10 cc's in the average patient at all these sites. And practices aren't that different in Europe than they are in North America. This is the actual safety profile for 500 patients with CLEAR. This data will show in Los Angeles, but will show groups A and group B. And you can see that 30-day mortality is 10%. There was no symptomatic bleeding when we used the protocol I showed you. 2% symptomatic bleeding. 8% ventriculitis, which is at or above the best level for infection in this type of severe patient. There's the mortality curve for the entire 500 patients. The mortality isn't 50%, it's 25%, and it's 25% at a year. So if you like historical comparisons, mortality is looking pretty good. What about withdrawal of care? Those are the instances of withdrawal of care. You can see that almost all of them were in the hospitalization time frame. They represent 10% of the deaths, and they actually were equally distributed in active treatment and the saline treatment. Functional outcome. 20% is what happens in Sweden, where there's complete access to care, where everybody has a decision made by an academic stroke doctor and neurosurgeon. At 30 days, we had 20% good outcomes. And at 180, the average was 45% good outcomes. So it looks like this may be an outcome shift too. So let's sum up. What will clear treatment comparisons show? I can't tell you, but we will show them. But what we do know from looking at this data is that there appears to be a mortality shift if you use historical comparison, and the mortality shift is accompanied by a historical MRS shift as well. So if I go back to what I said, the analogies I made to Werner's talk, the idea of removing blood from the brain so that it doesn't injure tissue further continues to be a strong idea, and I hope we continue to test it in large randomized clinical trials. Thank you very much.
Professor Hanley, dear Dan, many thanks for this excellent lecture, for sharing with us your insights over many years, decades, I must say, from experiments to the clinical application. I think also you made us curious. I understand that we may be looking hopefully into the future. Are there questions to Professor Hanley? I think we have time for one or two questions. Professor Brenin?
I would very much like to know that whether you assign a different natural history to basal ganglia hemorrhage as opposed to thalamic hemorrhage, because it seems that the Novo 7 experience suffered from this problem a little bit.
Yes, I think it's a critical question. If I understand you correctly, you're asking, did we assign a different natural history to the thalamic ICH location in this subset of large IVH with small ICH? And the answer is yes. In the phase 2 data, there was a likelihood of poor outcome that was much higher, odds ratio of 8 for thalamus. So one of the things that I'm saying to you as we look at our data today, the 10% shift in the sample of patients in phase 2 clear to phase 3 clear, a 10% greater number of thalamics push the likelihood of poor outcome lower. So if we list out the severity factors for ICH now, ICH clot size, IVH clot size, location. Location has to be more complicated than thalamus or not, but that's our current dichotomy. Those are 3 of the main ones. There probably are others. So you can see how complicated it is to do a randomized trial. And if those factors aren't balanced, they may account for a different distribution in outcomes. Similar to an M3 clot in ischemic stroke is not the same as a carotid T occlusion. We found the same situation in the CLEAR 3 data, that the thalamic location was a more severe location. You'll get to see that. But that's why we chose the adaptive randomization. And the thalamus location, as you saw, was balanced across the whole sets of sites. It was balanced between Europe and North America. And it's balanced between treatment A and treatment B.
Okay, thank you very much again, and we're looking forward to presentation of your data in Los Angeles.
Thank you.